Well, hello, everyone, and welcome to the EMDR Maven podcast. I'm Julie Miller. I'm a licensed professional counselor and an independent addiction counselor. I'm an EMDRIA approved basic and advanced EMDR trainer, an EMDR Institute regional trainer, and an EMDRIA approved consultant and certified therapist. I provide basic and advanced training through the EMDR Development Center. You can learn more about that at the website emdrdevelopment.com. This is season 2 of the EMDR Maven podcast. We're going to be discussing the use of EMDR therapy in the treatment of addictions, both substance and process addictions. I'll be happy to discuss any of your questions here on the podcast. We'll also have some other EMDR consultants who specialize in this area talking about their work. I host an EMDR no-fee study group on the last Wednesday of each month, except for December, from 12 noon to 12:50 p.m. Arizona time. This group is for anyone who's completed the EMDR basic training, and we can talk about addictions there as well. So send me an email, and I'll be glad to send you the link to the Zoom room that we use for that consultation group. You can contact me at jmiller4721@gmail.com. So send me an email with any questions you have, or if you'd like the link to the no-fee study group on that last Wednesday of the month. Today we have a special guest, Sarah Osborne. She's a compassionate and dedicated licensed professional counselor, licensed alcohol and drug counselor, and a nationally certified counselor. She's also a certified EMDR therapist, an EMDRIA-approved consultant and advanced credit provider, and an EMDR Humanitarian Assistance Program facilitator. Sarah specializes in the treatment of addiction, complex trauma, and dissociation. With experience in both community mental health settings and private addiction treatment centers, she's passionate about integrating EMDR therapy into addiction care at all levels. Sarah's been practicing EMDR therapy for over 10 years and is deeply committed to the intersection of trauma and addiction treatment. In her EMDR practice, Sarah provides a safe, supportive space for individuals from all walks of life struggling with addictions, dissociation, and complex trauma to help them heal and grow. She offers both individual and group consultation to EMDR clinicians and consultants in training, fostering development and connection within the professional community. She sponsors a local EMDR professional group to support ongoing learning and collaboration. She also provides advanced trainings and community presentations on the topics of EMDR and addiction and trauma. Sarah's dedicated to service, and she works closely with a local trauma response team, offering presentations and debriefings to support the mental health of first responders in her community. Welcome, Sarah, and thank you so much for joining me for this conversation about EMDR and addiction. Tell me a little about how you decided to get involved in EMDR. How did you get trained? Why did you get trained? Tell me all that.
So at the time, I was running a outpatient facility working with addiction, and I'd been working in the addiction mental health field for probably about 6 or 7 years at that point, and it was just this constant recurring feeling where clients would have a relapse of symptoms and they would come back, and there was this essence of hopelessness of like, I've done the work, I've gone to the meetings, I've checked the boxes, like, why do I keep coming back? Why am I here? And the conversation we're always having in that situation is like, well, there's this underlying thing. There's this trauma, there's this stuff that's happened during addiction, before addiction, throughout your lifespan, right? And this is the stuff that we really need to deal with. But I felt like I didn't have an effective way to deal with it, to talk about trauma in a situation where somebody's also on the other side talking about how they have cravings for heroin felt very like, it just felt like I wasn't doing anybody any favors. So at the time, I started doing some research on different modalities that were out there, trying to look for things that felt like they would be a better fit. And at the time, I was also fortunate enough to be working at a facility that really felt passionately about cutting edge treatment, and they felt passionately about making sure that if we found something that looked like it could be effective, that we got trained. So I found some articles at that time, some research that spoke to the efficacy of EMDR with addiction. And I brought it to the owner, and he approved that I could go get trained in EMDR. So at that point, I got trained. And for me, I will tell people, I feel like I drank the Kool-Aid then, right? Because I
Yeah,
came back
right.
and I started doing it with my clients. And all of a sudden, there was this shift. And like clients were reporting feeling hopeful, feeling like they actually had power for change versus just feeling like they should change. They felt like there were choices. And I was lucky enough when I got trained that I was also connected with Hope Payson, who's another person who does addiction and EMDR. The trainer, I got trained by Karen Alter Reed, and she connected me with Hope. And I was very fortunate because it meant that I really got a lot of support and information up front about working
Nice.
with addiction with EMDR.
That's a great couple of people to get involved with, to get connected
Yes,
to. Yeah.
yes,
In fact, we talked with Hope in she had an episode, I don't know, a couple of episodes ago, and it's just so amazing what she's doing. It's
yeah,
great. And she wants to retire. And I'm like, no,
yes,
we're not going to
yes,
we'll allow that. No, that's
yeah,
not going to happen.
yeah. Her and I are currently working on a book together.
Oh, nice. Yeah, that's great. She was telling me about the book that's you guys are working on.
Yeah,
And I think it's brilliant. I mean, I wish I was in a rehab facility where I could use that,
right,
because I think it's so important. It's not just trauma processing. EMDR therapy can
right,
do so many more things, and so I would love to see that integrated more in the
right,
treatment facilities we have around. So yeah, she's a gem,
right.
and you're fortunate that you got a lot of good connection with her. That's nice.
Yes, I am.
Yeah, yeah, great. So tell me, what's the work that you do now primarily with EMDR and addiction? Are you working with addiction clients? Are you in a private setting, your private practice, or are there other places you do that work?
So I work primarily in my private practice, and I do all of my clients have some form of addiction, whether it's substance or behavioral. And then in collaboration, I have helped a couple different treatment facilities integrate EMDR into their addiction facility, whether it's
Mm,
inpatient or outpatient.
hmm
I also do trainings on addiction and EMDR, and it's a group I'm passionate about. As I said, like that moment of seeing clients go from the hopeless to the feeling hope.
hmm
It just really changed things for me. So I've stayed with
mm,
it because the access to care for clients with addiction is tough. There aren't a lot of providers that feel capable or competent, unfortunately, when working
hmm
this with this population with EMDR.
Right. And I think there's also, at least this is true in Arizona, there's a history, of course, of a lot of folks who didn't have advanced degrees, weren't trained to be counselors or therapists, that just kind of transitioned from their own recovery into
Yes.
working with people who were trying to find recovery, and so didn't have a lot of professional training. And
Yep.
I think that's one of the issues. It's still kind of a legacy in Arizona, is the professional training for addiction is really lacking.
Yes.
And we have a lot of gaps in people who really need to have that good training and advanced degrees to work with the addiction population. So they kind of are underserved in many
Yeah.
ways in Arizona.
Definitely. And here in Connecticut, there's a lack of access to care. If you are not headed inpatient or into a agency that's doing more intensive work, there's like this lack of access for people that are home, going to work, doing what they need to do, but still need
Right.
addiction treatment.
Mm,
Um, so I personally in my practice, I take insurance, and the reason is the access to care, right? Like I want people to be able to get quality care for what they need out
right.
in the world without necessarily having to go to an agency where they may or may not get the services that they're looking for.
Right. Exactly. And to have an experienced therapist working in, that field with that population is really important. So,
It is.
yeah, I do take insurance as well, and it's for exactly the same reason, because most of my clients are first responders,
Yep.
and they wouldn't be able to pay for private care. So,
No.
I chose to continue to take insurance so that I could make sure that I was available to folks that needed it. Now, what kind of crossover do you find with addiction clients who are also first responders?
There is a significant amount of crossover. It's just
Hmm.
there's a little bit more difficulty in the willingness to identify this as the problem. Sometimes they're coming to treatment. A lot of times, the way I find they're coming to treatment is this specific situation has happened, and
Right.
I need to deal with this situation. And it just so happens as we're doing intake, as we're getting to know each other, as we're building rapport, it comes out that, oh, yes, I also may drink a lot, or I might use, a little bit of amphetamine, Adderall here and there to stay up to get through my shift, or right. So
Right.
it's just, it's less, I find they less are coming to treatment for that, but it comes out that it is a pervasive underlying problem that
Yes.
often isn't talked about or addressed for fear of job loss or being shunned essentially by their peers. The unfortunate reality, especially with firefighters, is that if somebody stops drinking, there's a certain loss of trust if they walk into a situation and aren't willing to partake in kind of that social norm. So it's a tough thing to manage in that environment.
In law enforcement, it's called choir practice. It's a little
Yes.
bit, old
Yes.
fashioned, not happening as much anymore, but it's still there.
It
So
is.
after work, you go and get a bunch of beers or alcohol with your buddies.
Yep.
And so the pressure to drink, to be a part of the brotherhood or
Yep.
sisterhood really is profound. And the same, I think, is true with firefighters. We
Yeah.
had a firefighter not long ago who really died as a result of his drinking. And
Right.
his drinking escalated tremendously because of post-traumatic stress.
Yes.
And I wasn't at the service, but there was afterwards, I understood from several folks that there was a kind of a circle of his mates, his workmates, and they were all passing around a flask. And it's like, this man died of
Yep.
drinking, and you're going to honor him by drinking. So
Yes.
it's so much a part of the culture, and there's a lot of denial about how it's a problem.
Yes. Yes. Especially, like so part of the work that I do that's not necessarily EMDR focused, but I'm part of a group where we go out and we try to provide education, provide stress debriefings, provide EMDR if needed to different departments that have gone through critical incidences. So
Hmm.
when somebody has a severe incident, the department will call us, we will come in, we'll do a debrief that's more clinically focused, less
Yeah,
like who did what. But the problem we run into time and again is people want to keep it in-house. They don't want the outside person coming in. And this
right.
is, it's that same kind of denial of symptoms, denial of it being an issue of, the old school thought that we should just pull up our bootstraps and we can do this and we'll get
That's
through
right.
it together. And
Right.
um, especially with the addiction, the underlying addiction in the firehouses, one of the recent groups we talked to, they were joking around about, if we were going to do a presentation, we would need to bring our own water because their fridge only has beer. And it's like, that's a standard norm,
Gosh.
right?
Yeah,
Like,
yeah.
but like, what does that say about the population
Exactly.
that that's a
Exactly.
standard norm?
Exactly. Boy, that's something, isn't it? Yeah. It's an ongoing problem, I think, for
Hmm.
first responders of all kinds, but it's
Yep.
definitely a part of the culture
Yes.
significantly. Now, have you used any group protocols in the work that you do for kind of the critical incident stuff? Do you do any group stuff?
So occasionally I will do group stuff. Often at that point, I'm using GTEP,
Yeah.
um, which I find to be pretty effective. People,
Yeah.
people are pretty willing. It's not one of the ones where people get confused by it. So when I do individual therapy, some of the first responders, when I start talking about the calm state, they're like, ugh, this is a little foofy for me, right? But like
Right,
the
right.
GTEP, I find I'm able to get them engaged. They're willing to do it. They find it's helpful. It doesn't feel
Yes.
too much out of their realm. They're
Yes.
they seem willing with it.
GTEP is my favorite as
Yeah,
well. I've done
yeah,
IGTP, the
yeah,
Nacho Herrero protocol. I've done that too. And I think the first responders I worked with were took to the GTEP a little bit better.
okay,
So I like that one a lot. And I wonder, because group is such a big part of addiction treatment, how
yeah,
that can be integrated with EMDR. I know that there's resourcing protocols. I remember one that I learned from Hope and is in the group protocol book
yep.
by Reg Morrow. And I wonder if there's any other group work that you've done for just really focusing on the addiction, not so much resourcing or trauma. Anything like that you've done, like the Crave
So
X or something in group?
So the addiction stuff that I've done in group, and this kind of ties into that book that Hope and I are doing, is really looking at kind of the negative cognitions that have been developed as a result of the traumatic experiences, and then doing focusing really on more of like a positive future template, like from Detour or doing identifying triggers and then doing a little bit of trigger desensitization work, really
Mm,
trying to keep it tight to the target, but really
right,
focusing on having the clients, not that we don't want them to share, right? But we don't want them to activate each other. So trying to
right,
keep the sharing down to a minimum during that
right.
time. But I wouldn't say it's a specific protocol that I'm doing by any
Okay,
means in
gotcha.
that way.
Okay, good. Yeah, I'm always asking about the group protocols because I love group. I did
Yeah.
group, all the time in addiction treatment, and I just love the group protocols with EMDR. So
And
it's
I think
nice
the
to
addiction agency is like that's the biggest access to care people have in the addiction agency is so
mm-hmm,
much of that work is done as a group. So
mm-hmm,
we do need effective ways to treat people or prepare people to do the EMDR work
definitely.
in addiction.
Yes, definitely. And that training needs to be more available than,
Yes.
it's nice that we have online trainings now, so you don't have to travel somewhere to get those trainings. But we need more of it specifically focused on addiction for sure.
Yeah.
Yeah. So tell me about what kind of protocols are you using? What do you like to use in the addiction focused work? Do you have
Yeah.
any favorite ones?
I would say my tried and true are probably feeling state addiction protocol, the gym knives urge to avoid, and
Mm-hmm.
then some of the detour. Detour, I go in and out of detour versus using standard protocol to address triggers. It just depends
Mm-hmm.
on the client, depends on which way I go.
Yeah.
But the urge to avoid, I would say, is like I smile because it's the thing that you run into the most with addiction, right? Is like I don't want to do the thing because. I don't want
Right.
to go to the meeting. I don't want to call the person. I don't want to work with my sponsor. I don't want to, whatever it is, right? And that
Right.
level of urge to avoid really allows you to help the client find why and helps you identify with the client what the underlying trauma is. Because, like, I think for EMDR treatment providers, we're able to identify those negative cognitions and themes pretty quickly. But I
Mm-hmm.
do think it's really powerful for the client to be able to work through systematically in their own mind and arrive at those conclusions on their own.
Yes.
Um,
It
so
really sticks better.
it does. And
Yeah.
they find more motivation to make those changes at that point, right?
Yes.
And when I used to work in a residential, I used to use the level of urge to avoid for clients who are actually trying to discharge against advice, right? Like we would target, how much do you not want to stay in treatment right now? How much do you want to leave? And it often was effective in helping them really weigh out the pros and cons. One that's less addiction focused, but is one that I use a lot in addiction is the two-handed interweave, again,
Yes.
to increase motivation, right? To
Mm-hmm.
help the client come to their own conclusion.
Mm-hmm. Right. When they have two options and they're waffling between them, it's a great interweave to
Hmm.
use. Yeah. Now, with people getting either freshly into EMDR therapy, they're new trainees perhaps, and maybe they have an interest in addiction, or they're just, they're EMDR therapists who've never worked with addiction before. What recommendations would you have for them? What kind of advice might you give somebody in that position?
I would say seek out a consultant who specializes in addiction, right? I think there's a lot of stigma just generally around addiction, but I think there's also a lot of fear in working with addiction.
Yeah.
The things that I hear from clinicians during the trainings is, I'm so scared that I'm going to trigger them and that they're going to go out and use and then they're going to die and it'll be my fault, right? Like that's, I think,
Mm,
the catastrophic thinking sequence of events for a lot of therapists is that I'm going to trigger them, they're going to use, they're going to die, this is my fault. And like, I
mm,
think if you're working with somebody who already has a lot of experience working with addiction, which again, I was very fortunate to have,
yeah.
it allows you to better understand the nuances of EMDR with addiction, which then allows you to build your confidence. And I think that's a large part of what working with EMDR and addiction is you as the therapist feeling confident in your clinical choices so that you're less hesitant and you're more intuitively able to stay aligned with the client versus focusing specifically on this is protocol A, so we need to check this box and get through this thing. It's more about where is my client at and how do I meet them there and what strategies and protocols can I use in order to get there.
Right. So it really needs to be more, in some ways, a here and now decision,
Yes,
not so much about, well, this is my plan for the long term for this client. It's like, what's going on for them right now? And
right.
what do I know I can do that would be beneficial right now to help move them to
Yes.
the next step? So I think probably as therapists, we catastrophize just as much as anybody else.
Yes.
And for some people, addictions are scary because
Yeah.
people do die from them.
Yep.
But, people die from lots of mental health issues. So I'm not
Yes.
really sure why addiction is that much scarier than anything else like suicidality or
Right.
dissociation.
Right.
But for some reason, it is.
Yeah, I think it's just a lot of the news around, the opiate epidemic, the opiate crisis, the fentanyl overdoses. I think people are just afraid that they're going to be the person that's responsible. And
Mhm.
one of the reasons I love EMDR is because I, as the clinician, is not responsible, right? Like
Right.
I am here to walk beside you. I'm here to help you come to your conclusions, but I am not the authority in the room.
That's
And
right.
to me, it alleviates you of the responsibility of I triggered the thing that caused the thing that caused the thing, right? It
Right.
really puts you in a position to walk next to your client and support them, but allow them to really find their own choices.
And I have learned over time to really trust the client's brain.
Yes.
And that if they're walking around and they're able to get to your office and they're standing upright or getting somewhere, they're mobile enough,
Hmm.
then their brain is likely to be able to benefit from this kind of work and
Right.
will do what it needs to do to protect itself or just get better. So
Right.
trusting that EMDR is going to be the the mechanism through which the clients get better and
Hmm.
that their brain is going to process what needs to
Right.
be processed.
Right.
And so much of the addiction focused protocols are really different
Yes.
from standard protocol. I mean, there's one that's very similar. The CraveX is very
Yep.
similar,
Yep.
but the other ones are really quite different, and you really do need to know more. You can't just
Yes.
know standard protocol. You need to know more and be able to trust the client that their brain is going to do what it needs to do,
Yep.
and trust that you're going to do it in accordance with, good fidelity with the
Right.
models.
Right.
So when you're working with your addiction clients, are there kind of standard go-to resource things that you do, or is it just, it really varies by client, of course, as to who needs what? But do you have anything in particular you really like to use with addiction clients that you find particularly helpful for that population?
I will say the calm state is not always helpful. I find with
Yeah.
this population, there's a lot more contamination that occurs in there. So
Hmm.
I tend to
Hmm.
I actually lean a little more heavily on DBT skills initially during that resourcing
Ah,
stage, as
nice.
far as emotion identification and emotion regulation. The big thing that I really implement with my clients is a lot of psychoeducation on the window of tolerance and having them do some window of tolerance tracking so that
Mm,
we can better understand their bottom and top as far as dysregulation before we're outside the window of tolerance
hmm.
and then focusing individually with them on, okay, if you're at the top of your window of tolerance, which specific coping skill works for you?
Mm,
Which regulation strategy works for you in that
hmm.
moment versus when you're at the bottom of the window of tolerance, which one's going to work there? The problem a lot of my clients that I see is that in the past during treatment, they've been taught about coping skills, but they've never really sat down and thought about which coping skill applies to which feeling. So trying to help clients get a little bit deeper with that. But like you said, it is very individualized. People really like the light stream and the spiral technique. Those
Yeah.
are ones that seem to be calming and they give the
Hmm.
client some feelings of power, I think,
Hmm.
to be able to kind of guide it and move through it.
Yes. Nice. I actually like those too.
Yeah, yeah.
They're good ones for calming and containment too. The spiral is particularly useful for
Yes.
containment, I think. So,
Yes.
yeah, that's really good stuff. So, what do you offer to other EMDR therapists? Do you provide consultation? Do you have group consultation? What kind of work do you do with other EMDR therapists?
So I do all the things. I do for people who are getting basic trained, I will do basic training group consultation. For people who are kind of working towards certification or have finished basic training, I have groups. I do individual consultation. And then I also work with CITs, doing consultation for them. And then I also offer advanced training on EMDR with addiction, really more on the focus of case conceptualization and how to integrate the different protocols versus just focusing on one specific protocol.
Hmm. Yeah, I think it again, it's an art form,
Hmm.
and which protocol is going to fit in which situation with which
Yes.
client. It really takes both experience and training in a lot of
Yes.
protocols, really, I think, to be able to
Yes.
make that clinical choice with the clients.
Yes. To be able to effectively really maneuver it, yes, it
Hmm.
takes, I think you do have to be willing to do a little bit extra training with the addiction
Hmm.
protocols. I think they are very effective if you truly understand what you're targeting,
Yes.
but sometimes even like the words maladaptive positive feeling state, right? Like it's a
Hmm.
mouthful and it feels overwhelming for a lot of people when they first hear it. But once you get trained in the feeling state addiction protocol, it just clicks and makes sense. So if you're
Hmm.
willing to get that training, I think a lot of it becomes second nature, but it is a willingness to do more training.
And to really have to practice it, get experience with
Yes.
it. Just like when you and I we were getting our basic training, you have to use it, to
Yes.
really get a good handle on it. And I think the same is absolutely true with the addiction protocols.
Hmm.
And probably my favorite is the feeling state addiction
Yeah.
protocol. It still amazes me whenever I see it
Yes.
working. I'm like, wow, this is so cool. And I would
Yes.
like to do more of it. I don't do
Yeah.
enough of it because it's just fascinating to me how it works. The only thing I think with the feeling state addiction protocol, I don't see a lot of generalization
Right.
between like Robert Miller, the developer of
Yep.
feeling state addiction protocol, did one of his initial articles on food
Right.
and it food addiction. It doesn't generalize to more than whatever the one food is that you start
Right.
with that. It doesn't generalize to other foods, even other foods that share feeling states or
Right.
other foods that share components like bread and I don't know what's similar to bread, whatever might be similar to
Yeah.
bread.
Yeah.
They just, or other dairy things or something
Yep.
like that. They
Yeah.
just don't seem to generalize.
No, I agree. Because I have a woman who I have done it a few times with her. And at one point we were doing chocolate. And then, like, a few weeks later, we needed to do Rocky Road ice cream, right? And, like, even though those are both very chocolatey, right? And they
Mm-hmm.
shared a similar feeling state and a similar
Mm-hmm.
origin to that feeling
Right.
state, we still needed to do it again in
Mm-hmm.
order to really have it stick.
Yeah. So I'm really, if I was a younger person, I would probably want to do my dissertation on something related to the feeling state and what we could do to alter it so that it would facilitate more generalization
Yeah.
between things, like cigarettes and smoking pot. Okay, maybe
Right.
not all use of pot, but the smoking element,
Yep. Yeah.
is there a way we could get it to generalize to that because there are similar dynamics,
Right.
but it doesn't generalize. So I
Yeah,
think
that
it's,
gets me thinking. Now I'm
oh,
going down a
good.
rabbit hole. Yeah.
Oh, good, good. I'm glad you're going down a rabbit hole because I really want somebody to do that work. It's not going to
Yeah.
be me.
N- If it's me, I don't know if it'll be anytime soon. I have a couple of things on the list before then,
Couple of things on the list.
but like as you're saying it, I'm thinking about it and I'm like, is it the network? Is it the this? Is it the that?
Hmm.
Like, yeah. Hmm.
Yeah, what keeps that from a little bit more generalization?
Yeah.
Well, look into that for me, would you?
I
Because
will. I'll get back to you.
I'd really like to know. I think it would be so great to have something that we could use that would be more generalizable. And I
Yeah.
also think the feeling state addiction protocol is pretty complex
Hmm.
because there's, if you don't quite tune into that feeling state,
Yes.
you're going to miss the boat. It's
Yep.
not going to be effective. So
Correct.
there's a lot of potential there with that one, though, I think.
But I think that's also where being truly trained in the nuances of the addiction stuff, right? Like not
Yeah,
only having a consultant who knows addiction, but also that willingness to go get trained in the addiction protocols. Sometimes I have people who come to consultation that tell me, like, I've read the protocol front to back. I don't understand why it's not working. And like you were just saying about the feeling state addiction protocol, it's really getting the nuance
yeah.
of getting that feeling state in there. And
Hmm.
that's part of it is being willing to get the training, not just read the article.
Right. And talk to people who do use it a lot,
Right.
who do
Right.
know what to do if you get stuck or the
Yes.
wheels fall off or it's not being
Yes.
effective. Yeah,
Yes.
important stuff. So, when are you planning on presenting again? Are you going to do the EMDRIA conference coming up in 2026?
I don't know yet.
Okay.
But I do have a addiction training in January.
Oh,
My
nice.
next training is January. Yeah.
What's the addiction training you're doing that's anybody could participate in?
Yep. So the one that I hold, it's a 12-hour EMDR and addiction. Its focus is on case conceptualization and then briefly touching on all of the different addiction focused protocols and kind
Mm-hmm.
of how to integrate them with addictions clients. It gets into a little bit how to effectively use it with clients who are still using or who are in early recovery. I
Mm-hmm.
touch on things like anhedonia, so like that absence of
Mm-hmm.
feeling in early recovery that people go
Mm-hmm.
through. Really just trying to help people feel like they can understand and make a difference with
Mm-hmm.
addiction and EMDR.
Nice. How could our listeners contact you? How could they get in touch to ask for consultation or to just talk to you about a group or something?
Yeah,
How would you like them to find you?
there are two ways, either through my website, which is sarahosbornecounseling.com, or I have an email address, osborne.consultation@gmail.
Okay, that's nice and simple.
It
At Gmail?
is.
Yeah, that's nice and
Yes.
simple. Really appreciate your time today
Yes, thank you
and
for having me.
willingness
This was
to.
fun.
Good, I'm glad. It was just nice to see you again.
Yes.
Since it's been such a long time since we last saw each other.
Yes.
Pre-pandemic, pre-end of the world, right?
Yes, I know. We
Yeah,
were out in a hotel having dinner at a
we were.
table with other people.
I know, people around us and breathing each other's air. It was,
Yeah.
yes, what a difference that brought into the world, isn't it?
Yes.
Yeah.
Things changed. Yeah.
Thanks again. All my thanks to Sarah for coming and joining us today in this conversation about EMDR and addiction. We mentioned several different addiction focused protocols, the feeling state addiction protocol, the CRAVEX, the detour. We also talked about group protocols like the IGTP and the GTAP. I'm going to spend a little bit of time in the next few episodes talking more about those in greater detail. I think it's not enough for you to just listen to one of those episodes about one of these specific protocols to be able to use it. But I really want, if anything, to just pique your interest so that if you haven't gotten the training in these protocols, that you seek it out. There is training available, and I think it's really important if you're working with addictions that you learn how to use these addiction-focused protocols. There isn't one that is the magic protocol. It's really important to know what to use in what circumstance. And then you can use, as Susan Brown often says, pieces and parts. So there's a part of a protocol you're going to use for someone because that's what they need at that moment. And then you might use another part of a protocol. So it's important to learn more about those. So those will be coming up in future podcast episodes. And I'm hoping to be able to share that with you all soon. If you have any questions or you have anything you would like me to talk about or have someone, a consultant, talk about regarding the use of EMDR with addictions, please let me know. You can send me an email at jmiller4721@gmail.com. That's jmiller4721@gmail.com. And I'll talk to you all again soon. Thanks for listening.